Hi, my name is Connie Koklanis and you're watching the video Brown Syndrome Management. In this video, we'll discuss both non-surgical and surgical options in managing a patient who has been diagnosed with Brown syndrome. As a general principle, when a patient has Brown syndrome, it is best to leave them untreated if they have no deviation in primary position. Recall from the previous video that patients with a Brown syndrome, when it's congenital in nature, can have spontaneous resolution of their Brown syndrome. Also, patients with inflammatory disorders can have fluctuations or changes between times when they have limited elevation and times when they don't. But focusing back on that congenital patient, you need to wait to see whether there's spontaneous resolution of the Brown syndrome. The other factor, as you will recall, is that as the child becomes older and moves into adulthood, their height is obviously going to be more, and therefore they're not going to be utilising up gaze as much. And as such, the Brown syndrome becomes less of a cosmetic issue, particularly if you're looking at a patient with just a mild Brown syndrome, where the only position affected is elevation in adduction. How long should you wait for spontaneous recovery? Some studies suggest that this will generally occur by the age of about 15. So you should wait for at least this length of time if your patient presents to you as an adult. If there is still significant Brown syndrome there, then you can assume that it's likely not to recover from here on. Although, mind you, there are, just to complicate things, cases of spontaneous resolution in adulthood. Where you do want to assist a patient with non-surgical options, the best options are assisting patients to utilise an abnormal head posture or to move their head instead of their eyes. Patients become actually very good at being able to move their head rather than their eyes to avoid having the misalignment of their eyes become transparent. So in other words, if a patient has a moderate deviation and a downshoot in adduction, if they simply move their head into the position of gaze where they would otherwise have a downshoot, then others around them won't notice that there's a misalignment of the eyes in that position. Also, if the problem is in upgaze or there's significant issues in upgaze, if they simply move their head up, then this will alleviate the issue of people noticing that there is a misalignment of the eyes. Aside from the cosmetic issue, it also assists in the patient avoiding having diplopia. As they move their head rather than their eyes, they'll actually not experience diplopia. If they move their eyes instead, obviously the downshoot or the limited elevation, for instance, will create issues for the patient. So when do we consider surgery? Well, when there is a primary position deviation, so we have a hypo deviation, we would consider surgical intervention. Or if the patient has to utilise an abnormal head posture that's quite uncomfortable or very large to achieve BSV. And in this instance, you've got a patient often with troublesome diplopia. So really you're looking at operating on a patient who is classified as having a severe Brown's syndrome. Those with mild and moderate can generally be left untreated and utilise non-surgical options such as moving their head rather than their eyes to avoid diplopia and maintain, from their perspective, an acceptable cosmesis. What surgical options are available to a patient with a Brown syndrome? There are several options, and we can actually divide these between patients who have congenital Browns and acquired Browns, and let's commence with those who have got a congenital Browns. So remember, a patient with a congenital Browns generally is considered to have either a short or inelastic tendon. And even though this may be controversial, the treatment options for a congenital Brown seem to be successful in these patients. So one option is a superior oblique weakening. So if you weaken the superior oblique with a procedure such as a tenotomy, this will reduce the mechanical limitation that we see in elevation or of elevation in adduction and can assist the patient in terms of their diplopia and cosmesis. We could also lengthen the superior oblique. Remember, it's often short, and so by lengthening it using a silicone spacer or expander, we can again weaken the superior oblique and assist the patient achieving elevation in adduction. This is actually one of the more popular procedures to undertake in a Brown syndrome. Now, if procedures to the superior oblique fail to achieve a good outcome for the patient, then you could look at moving to the contralateral superior rectus and weakening this. In essence, by doing this, you're looking at matching the defect between the eye that has the Brown syndrome and the eye that has the overacting superior rectus. Let's have a look at an animation of a Brown syndrome and then of a patient who's been provided a silicone expander to the superior oblique to improve ocular movements. Here we have the left eye, and this is the inferior oblique that will try to elevate the eye in adduction. And this is the superior oblique that is short and not allowing the eye to complete its action of elevation in adduction. So, looking at this, here we go. We see that the eye can't elevate. So, this is the inferior oblique trying to pull the eye up, and the eye is just not getting across. It's coming into adduction but not really elevating up. And what's restricting it is the superior oblique. It's just too short to allow the free movement of elevation. Let's move on now to an eye that has a silicone expander. So again, same image. Here is the inferior oblique. Here is the superior oblique. And now we'll see the silicone expander added. Okay. So there we have the division of the superior oblique, the silicone expander added, and now the eye will try to rotate. Okay, so now we can see the eye elevating as well as adducting. Why? Because we've got much more length here of the superior oblique, and so we've got more freedom of movement in adduction, allowing that eye to elevate in that position. Let's now move on to patients with an acquired Brown syndrome. In this instance, you want to look at the cause of the Brown syndrome and, where possible, manage the underlying condition. So if it's an inflammatory disease, manage the inflammatory disease. And this should hopefully assist the patient with their Brown syndrome. If the underlying issue is that the patient has had an over-tucking of the superior oblique, look at this. Look if you can reverse that tuck procedure, and usually a tuck procedure can be reversed. So try and determine in an acquired case what is the cause and then see if that can be managed. Okay, so in summary, with a congenital Brown syndrome, leave them untreated unless they're severe. So just assist them if they have issues with moving their head instead of their eyes, or with an abnormal head posture if required. But make sure that abnormal head posture is comfortable and not very large. So in severe cases, then look at surgical intervention, and in this instance one of the most preferred options is looking at adding a silicone expander to lengthen the superior oblique. And finally, where you have an acquired Brown syndrome, manage the underlying condition where possible. Okay, that brings us to the conclusion of this video. Thank you for watching.